Thank you very much, Lydia. My name is Jeyasingam. I'm the head of the Faculty of Old Age Psychiatry with the New South Wales Faculty of Old Age Psychiatry and the College of Psychiatrists. I'm a senior clinical lecturer with Sydney University. My private practice is at My Health Barangaroo, and that is my website. And I've been asked to speak to yourselves regarding BPSD management and how to keep elderly patients out of aged care facilities. There's a lot of information that I'm going to put inside this slide, which I'm not necessarily going to talk through word for word. The broad context of this is that I'm going to be discussing some basic neurobiology regarding the different kinds of dementia in order to lead to questions as to what to do with the individual dementias, and then more broadly regarding how to keep older patients out of aged care facilities. At any point, feel free to type messages, which I can see inside the chat, and I'll try to answer them as you go by. We'll try to leave some time towards the end as well if anyone has any questions. So without any further ado, we'll talk about what dementia specifically is, which is a complicated question because it has actually changed quite a bit. Even current up-to-date criteria regarding what dementia is varies quite significantly. Many people consider it as being a level of memory impairment. Some of it talk about it as being a cognitive issue. The most recent version of the Diagnostic and Statistical Manual, the 5th edition, doesn't have the word dementia at all. Instead, people it was decided that the word dementia was too pejorative, and therefore everyone was encouraged to use the much more user-friendly term major neurocognitive disorder of degeneration, with the idea that this reflected more accurately a issue where a person has significant cognitive decline from a previous level of performance in at least one cognitive domain. This had two repercussions. One of them was that you could not make a dementia diagnosis without a neuropsychologist. The second issue was that major neurocognitive disorder of degeneration sounds ridiculous. The key trends, however, is that we do think about dementia as being one of cognitive loss. We used to consider it as a non-progressive thing. So there used to be, so the old term for vascular dementia referred to a person who had major strokes and therefore had new onset static cognitive loss. We now think about dementia as being a progressive issue. There's a trend away from clinical criteria more towards objective things such as imaging and neuropsych. There is a recognition, before we used to think about neuronal dysfunction, and now we think about neuronal loss. Why this is important was a lot of people were being diagnosed with dementia who had treatable psychiatric conditions such as depression. Hence Leslie Kylo's 1964 seminal monograph on the presence of pseudo-dementia, which was about the importance of recognizing people who might be thought to have dementia who actually have depression. And despite overwhelming evidence, we're still not entirely sure about what amyloid has to do with most kinds of dementias. But where we come to discussing about dementias, there is a need for three aspects to be thought from a neurology perspective: the frontal lobe, the limbic system, and the medial temporal lobe. For the frontal lobe, fairly straightforward. We know that this the most sophisticated and largest part of the brain, which the seat of personality, abstract thinking, and higher cortical functions, is also where most of the dopamine-sensitive neurons happen to be. Many of you might recognize this radiograph or this postulated radiograph of Phineas Gage, from which we have determined many frontal lobe related pathological signs. The limbic system is much harder to describe. In fact, Gray's Anatomy varies each edition in terms of what is the limbic system. Classically, it's referred to as being an entity that handles emotions, with the neocortex managing cognitions. We've moved away from that to the idea that these have specialized functions but still an integrated whole, but even more recent theory is heading back towards the idea of the limbic system as being an interesting circuit of cerebral components which are associated with improvement with emotion processing. Now, for the medial temporal lobe, this is a very important region where the seizures in these areas can yield hallucinations and dissociative symptoms, and are often associated with schizophreniform symptoms. It's also where the hippocampus is, which is essential for encoding in memory. Now, neuronal loss in a lot of different areas of the brain are associated with subsequent behavioral issues, which is why it's so important to know where the person has neurological damage, because different presentations can be symptoms can be associated with very specific regions of neuronal degeneration. So What does that all mean? When we think about dementia, we have to remember that it's a brain disease. It starts, first of all, with neuronal loss, and we have to think about the function that is associated with dementia as being related to the location of loss. So with that in mind, how do we decide what kind of dementia that they have? The simple, straightforward way is to simply do two things, which is a mini mental and a clock face. For a mini mental, it's important about firstly asking the three items and then testing them immediately at 2 minutes and then 5 minutes. If they are unable to remember any object, provide a categorical clue first and then a list cue. So what I mean by a categorical cue is an abstract reference. So such as if you're asking them to remember so normally what I ask them to do is to remember things like brown shirt and honesty. For brown, the categorical cue would be the first item was a color. And if they can't get what that is, then the list cue is you give a list of items such as black, brown, or blue. If they are unable to answer despite both a categorical and a list cue, it suggests an encoding failure, meaning that it never went past working memory, which is what you often would see in Alzheimer's. If they're unable to answer with the categorical cue, but they're able to answer with the list cue, that suggests that there's an impairment in frontal lobe function. And if they are unable to answer spontaneously, but they can respond to a categorical or a list cue, that's probably a retrieval impairment, such as in a vascular or other process. You add this to the clock face. For the clock face, the first important thing is you draw the circle for them and ask them to fill in the numbers to make a clock. Then they put their hands in to make it 10 to 2. When you do this, you get a large amount of information. If they fill out things incorrectly and realize afterwards that there was something wrong, there usually is a frontal lobe impairment. There usually isn't a frontal lobe impairment. If they have difficulties in the construction, there may be a parietal or an occipital lobe construction. And you get a lot more information by how they go about doing so rather than, and particularly regarding their planning capacity. Now, for the different dementias, this is, first of all, the kind of brain that I would like to have if I'm 85 years old, because this is what we see as a normal brain. There is a decreasing overall brain volume with advancing age. In Alzheimer's dementia, there is early memory impairment with impaired encoding of the memory with subsequent subcortical and cortical deficits, with the seminal issue being hippocampal loss, which is leading to impairment in the encoding. By the way, they're still able to form emotional memories, and their long-term memory is often unaffected, which leads to the awful situation that you could give a person with Alzheimer's dementia bad news. They can be upset about it and then later forget why they were upset, but they can simply remember the fact that they were upset. And as tissue loss continues, other cognitive deficits follow. And it's extremely easy to tell on a CT or MRI scan. In fact, an MRI provides no additional benefit over a CT for differentiation of Alzheimer's. You very simply look for medial temporal lobe atrophy, as well as, curiously, precuneus atrophy. And these are visible in here with the large, with the relative loss of hippocampal regions in the right image on the screen compared to the left. For vascular dementia, there is a microvascular, there is something called microvascular dementia, which is the dominant statement nowadays when we talk about vascular dementia, of a progressive accumulation of microvascular ischemic damage with a subcortical pattern of deficits. And the older one was of a stepwise deterioration following major events. And that is not very commonly referred to in vascular dementia now. And this shows this axial flare magnetic resonance shows multiple subcortical hyperintensities with a clinical diagnosis of vascular dementia with no focal infarcts being seen. Lewy body dementia has a much worse prognosis, but interestingly a much better response, which we'll discuss later. Fluctuating consciousness, visual hallucinations, Parkinsonian features. And there is also often catastrophic deteriorations in the event of antipsychotic use. And what we know about Lewy body dementia is that it is probably Parkinson's in a different region. Both Parkinson's and Lewy body dementia are associated with alpha-synuclein pathology, with the alpha-synuclein pathology in the substantia nigra as opposed to different regions, as opposed to the frontal regions of the brain, which is what we'd be seeing in Lewy body dementia. It's not really appreciable on most imaging, but very, very strong clinical presentation with Parkinsonism and visual hallucinations. And then, and this MR shows significant difference between Lewy body and Alzheimer's. Again, note the relative mesial temporal lobe loss. In frontotemporal dementia, personality changes in impulsivity predominate early in presentation with several subtypes. There are at least 3 different classificatory systems which are currently arguing amongst themselves about which system is more superior. And they tend to have a poorer response to cholinesterase inhibitors due to increased agitation. You might remember the old PIX disease. PIX is no longer used because it refers very narrowly to a very particular variant with a particular histopathological finding, which is not very clinically relevant. It refers more generally to any progressive neuronal loss, which is related to the frontal and temporal regions more specifically. There is, by the way, a frontal variant of Alzheimer's, just to make it complicated, and even an occipital variant of Alzheimer's, but both of them still start with hippocampal or short-term memory loss. Some of the clinical subtypes include FTD, semantic dementia, and non-fluent aphasia. If you do see it's on imaging, it can be quite marked. In this image shows a frontal lobe knife-like gyri, which you can see the markedly wide and sulky preservation of the parietal and occipital lobes relative to the damage of the frontal lobe. The last one to consider is schizophrenia. We tend to forget that schizophrenia, the original term for schizophrenia was dementia praecox, which was precocious dementia, and it is a form of dementia with usually a frontotemporal pattern of dysfunction. There is evidence of regional dysfunction in the frontal lobe, temporal lobe, and limbic system. Interestingly, it is also one of the few forms of dementia that we have successfully treated. Recent evidence has suggested that early treatment of schizophrenia with antipsychotic therapy does lead to cognitive protection in later life. So without us knowing it, we have actually reduced the clinical load of one of the most common forms of dementia across the world. Relative prognosis from time, and this is very difficult to pin down because timing of diagnosis makes a very big change to the overall prognosis. It's worth talking very briefly about young onset dementia, just to note that there's a very wide range of possible causes. We also know that there's a wide range of differentials, particularly delirium. And what I like to do as a screen to look for delirium is the SQUID. The SQUID refers to single question in delirium, which is you turn to the patient's partner or carer and ask them, has patient recently become confused? This single question has been found to have in an excess of a 90% positive predictive value in determining whether or not a person may have delirium, because it takes into account collateral information as well as change in functioning and the most important issue of confusion, which not many other psychiatric features or dementing procedures can be associated with. That's my standard organic screen in order to try to look for what other issues could be contributing to why the person is presenting in this way. And I give all that basically to talk about the different kinds of dementia, how to try to rule out things before we go on towards the management of the BPSD. Were there any questions at that point?
No, Dr. Neil, not yet, not so far.
Okay, then. Well, we'll go on to the actual. Okay, we'll go on to the actual management. So the standard pharmacological management has been antipsychotics, as everyone knows, and the issue is that they are very effective in a way. It also comes down to the term BPSD, which is a catch-all phrase referring to anything a person with dementia does that we don't like, particularly agitation, wandering, and violence. Notably, wandering does not respond to most pharmacotherapies, despite heavy use of antipsychotics to try to control same. And we know that up to 90% of Alzheimer's, for example, patients will exhibit BPSD. Now, the reason why we use antipsychotics is because there was a thought that a lot of this was due to modulation of the dopamine transmitters, which were disrupted by the dementing process. But there's quite a lot of evidence that suggests that it's merely the sedation, which itself is not actually that strong. There is a very strong sedative impact in the first couple of weeks, which gradually wears off. And the atypical agents, because you had less EPSEs associated with them, as in extrapyramidal side effects such as Parkinsonism and stiffness, because you didn't have as much and they were still quite sedating, they rapidly became quite popular. It was in the 1980s where we discovered that, firstly with risperidone, and then we found that all antipsychotics that are dopamine antagonists are associated with an increased risk of cerebrovascular incidents. And most studies concede that the risk of cerebrovascular incidents for a person who is on antipsychotics is roughly 2.5 to 3 times their baseline risk. And when you consider that the risk of a person from age 65 to 85 having a stroke is already about 1 in 6, putting them onto antipsychotics commits them to a roughly 50% chance of stroke. Black box warnings have been associated with same, and which have been found in the US to be associated with reduction in prescribing, and considerable large lawsuits, particularly against quetiapine, have occurred regarding the use of antipsychotics for dementia, which is unfortunate because they work, particularly for psychosis. So, and you usually can get away with extremely low doses of antipsychotics and obviously people with schizophrenia, there isn't anything else you can really do for people with schizophrenia apart from antipsychotic therapy. And it's important to remember that we have things like that for when you're coming into psychosis, there are things like delirium, psychotic depression, and there are a lot of different medications that can induce psychoses, such as opioids and levetiracetam, which is a very popular anti-epileptic because it's the only anti-epileptic that does not cause hepatic impairment, but it has a roughly 30% rate of neuropsychiatric adverse events, together with within them, about 5 to 10% can have a particularly nasty aggressive psychosis. In terms of how aggressive, I have personally witnessed a gentleman eat a television whilst in a levetiracetam-induced rage. Once you see something like that once, you don't tend to forget it. It's also important to remember that even if they have schizophrenia and even if they are responding to the schizophrenia with the antipsychotic, you are still committing them to an elevated CVA risk. Unfortunately, the elevated CVA risk is true for all individuals who go onto antipsychotics. So I quite like Poole's algorithm as a nursing management approach for disturbed behavior in older people. If you look at the process, it's basically looking, first of all, about ruling out delirium and depression before going on towards assuming permanent care from dementia. So we have issues with, so we have to be careful about the term BPSD. It's more important to establish the patterns of behavior to formulate what's happening with the medication, and to try to assume, if you were the patient yourself, what sort of treatments would you like to have? And which is why what we would like to talk about is to think about the behavior in terms of what the specific behavior is, being really clear in terms of the time course, nature, associated features. Is this a new thing? Is this an old thing? Try to determine the psychology of same. Why would the patient do this? Is there a person-centered approach that would assist? Are they repeating something from their childhood or their earlier profession? Is there a constellation of signs and symptoms that suggest an underlying untreated illness? And do we know what kind of dementia we're dealing with in the first place? So in terms of the kind of dementia, if we are going to, so we have to move away from the idea that we are simply trying to sedate people. And let's think about the individual dementias. So with Alzheimer's, there is a limited response to antidepressants, sadly, even with people with depression, but they usually respond quite well to cholinesterase inhibitors such as rivastigmine and donepezil. For vascular dementia, depression is common and usually responds quite well to pharmacotherapy, at least compared to the Alzheimer's patients, and memory is generally better preserved. If the person doesn't have a lot of frontal lobe damage, they will respond quite well to cholinesterase inhibitors, but you have to be cautious if there is a lot of frontal behavior. For Lewy body dementia, these are incredible. So first of all, you absolutely cannot use antipsychotic therapies. You will make them fall, you will exacerbate their Parkinsonism, but they respond very well to cholinesterase inhibitors. In fact, the Cochrane review, which is normally a masterpiece of limited expectations, concludes its review of the use of cholinesterase inhibitors for dementia with saying that there is no further research that is necessary in this area, which I have not seen written anywhere else in the Cochrane reviews for any other reason. For the frontotemporal dementias, there is conflicting evidence about the use of cholinesterase inhibitors. Generally, we would recommend against their use, but low-dose SSRIs are useful for emotional modulation, citalopram 5 to 10 milligrams, and carbamazepine has the best evidence for use in their behavior management. This is the regime that I normally use. It has level 1 evidence for, actually it has level 1 evidence for all BPSD and all dementias. And there is a little bit of increasing evidence of lamotrigine and topiramate, but not quite the same as carbamazepine. A very important thing to know about for carbamazepine, however, is it is a difficult agent to use with high hepatotoxicity. The regime that I suggest from before will usually be able to have your patients reasonably well tolerated. The biggest concern is Stevens-Johnson syndrome, which is a form of toxic epidermal necrolysis. In the very early stages, the person can present with a generalized rash. It is usually apruritic, as in not itchy, can be on the face, the upper part of the torso. If that happens, immediately stop the agent and monitor them carefully. And if it continues, it can go on towards blister formation and extreme pain and one of the few dermatological emergencies. If it works well, it does have incredibly good results in terms of controlling all BPSD related issues. Very, very good for frontal lobe function. Hardly anything works any better than it. So those are the most important issues which I wanted to discuss about on BPSD. Any questions about that before we go on to the second part of this presentation?
Neil, I have no questions at the question pool at the moment.
Okay, everyone's enjoying their dinner. Then we'll continue on to keeping elderly patients out of aged care facilities. So the first thing is what you all do well, which is primary care. Physical optimization, looking at dementia progression and dementia management. In the future, we will want to see more agents try to slow down dementia and agents to prevent dementia. But there are only 3 features which have been found consistently in the literature so far to actually make a difference. One of them is exercise. Exercise is bizarre. It works way more effectively than we think it should. There are literally thousands of studies where the sole intervention has been nothing more than to have some sort of exercise regime. Before, we used to think it was only aerobic exercise, but now we know that anaerobic exercise does make a difference as well. And this has been associated with everything. Prevention of mild cognitive impairment, prevention of progression of mild cognitive impairment, prevention of dementia, resolution of previously existing dementia in terms of improvement of function. It does seem to do far more than it really deserves to. The difficulty is maintaining it, and it does have to be daily. So an exercise regime, it doesn't seem to matter what they do, but it does seem to matter that they have to do it daily. In my clinical practice, I recommend, because most of the evidence is still on aerobic exercise, I have my patients recommend to them an aerobic regime of anything that is going to get them slightly out of breath and to be maintained for at least half an hour each day. The next is on the cholinesterase inhibitors, and this is quite controversial. The dominant theory is still that the cholinesterase inhibitors don't change the dementia. Oh, I'm getting a comment asking me to slow down a bit. Yep, shall do. For the cholinesterase inhibitors, we've had a lot of information. The consensus is that they probably don't change the underlying dementia, because we do think about dementia as being a progressive accumulation of pathological states with neuronal loss, and the cholinesterase inhibitors basically improve the function of the remaining neurons. The problem with that is that there is now good evidence that the early commencement of cholinesterase inhibitors slows down patients transitioning to residential aged care facilities. Donepezil was one of the first ones to demonstrate this, and the other agents have done so as well. So early diagnosis of dementia, early treatment does seem to make a difference. How much is going to change over time? The next part is in terms of an adaptable personality, which is to look at, and this is to do with, this is part of the Neo 5-factor model of looking at personality theory, but a person who is able to respond to changes and take it in their stride tends to do better. There is less stress, there's less physical deterioration, there is less mental deterioration, and there is generally more cognitive protection. How do you actually create these? The first thing is we know that there are very good behavior management services which are now present. Your local BASES or DBMS or BAMS service, all of them meaning the same thing, as a behavior advisory service within the public service as well as in the private service. Alzheimer's Australia is also a great resource for how to access these supports. In terms of carer support, which is the next important issue, it is very important to make sure that the carer is well supported for what they need to have, which is within Carers Australia as well as Alzheimer's Australia. And the My Aged Care website has a usual start in terms of contacts for carers. So when we're thinking about aged care, there are 2 points. One of them is patient-related factors, and the second is on carer-related factors. For patient-related factors, we think about what is the behavior and why is it happening. So we talked about Poole's algorithm, which is particularly to rule out delirium and depression before you're going onto dementia. Then it is considering whether there is a pain issue, whether there is distress due to an unmet need, and whether it is attention-based. The problem with attention-based is that is usually commonly one of the first things that people assume with an older person presenting with a behavior pathology, and the others really need to be ruled out before you go on towards that point, because attention is a very pejorative perspective. The next thing is on the psychosocial interventions, and there are several of these: massage, music, PET. There are doll therapies. Many of these interventions have sprung up and have quite good evidences in limited studies. The problem is that all of these psychosocial interventions, none of these psychosocial interventions have been shown to have a consistent evidence base for all dementia subtypes. With one interesting exception, and that is birds. So having an aviary, so having something, a bird in some sort of a cage with birds inside it, and an opportunity for staff to take a patient to listen to it, consistently reduces agitation, regardless of the nature of the dementia. And multiple studies have actually shown this. So we know that whatever that you do with an individual patient, if it involves one-to-one contact between a staff member and a resident on a contracted regular basis, these all show efficacy. There's something interesting about birds because they seem consistently to have a benefit, not just regardless of the state, and not just in individual studies, but regardless of the nature of the dementia. So the psychosocial interventions cover things like day centers, reminiscence therapies, doll therapies, pet therapies, diversional therapies, music therapy, aromatherapy, gardens, sheds, chicken coops, and environments familiar to a person's early life. These are things that work not just inside residential facilities, which is where most of the evidence is, but they also work outside of residential facilities. So early access to day centers and respite opportunities do make a difference in terms of their subsequent transitioning. When it comes to the issue of environments familiar to a person's early life, there are very interesting experiments which have been done, particularly in the Netherlands, where people have constructed entire residential facilities that are disguised as villages, so that older people can feel as though they are going around a familiar environment with postal workers, some clerks, cashiers, in reality being nursing staff who are play acting as their individual roles. And the idea of this is to provide a familiar environment in order to mitigate aggression, distress, and agitation. This has been criticized ethically, but the results are very, very clear. They absolutely work. There has been evidence of improved quality of life, much less agitation and distress for the individual patients within these environments. There are currently experiments happening in Australia with setting up similar facilities. So from a carer support perspective, the carers very much need to be involved and need to be the more that you support the carer with with what they are needing to try to do to be able to support the patient, the more likely you are to be able to help to keep the older person out of residential facilities. So any services, cleaning, shopping, providing meals, transport, medication monitoring. Carer respite is a very important issue. Many people believe that they have to be looking after the individual until they end up in a residential facility, and then it's all over. With the issue of respite, it's about recognizing that they can have a couple of weeks break so that their loved one can go into a residential facility, can stay for a couple of weeks, their carer is able to have a holiday from their loved one, and it gives them an opportunity to be able to look after them again on a longer term basis. And it's important to bring in this idea of respite because it does two things. One of them, it greatly reduces carer burnout. Secondly, it more normalizes the eventual transition to a residential facility. And thirdly, it actually slows down the transition to the residential facility because the carer is better supported. It is good to know whether or not the carer has access to the carer's allowance in terms of their financial incentive to SAME. It is important to be aware of the risk for elder abuse, however, from SAME, because there can be a financial incentive for the person not to transition, which is problematic in terms of the risk that the person may not be in the right place. Another approach is to try rotating amongst family members, recruiting as many members of the family as possible so that different members of the family can take turns in terms of providing this care and support that's needed for the older loved ones. And have the early question of the predetermined exit plan. Many carers try to persist and then never think, when is the point when they're going to say, all right, that's it, I can't do this anymore. And this is important to have as an early conversation because there is a large amount of guilt that is associated with transitioning to a residential facility. And with that guilt, there is a lack of thinking about things like respite, controlling for burnout, supporting services. Having that predetermined exit plan as an idea makes it easier to be able to create all these other options. And it's important to remember all the gateways, the aged care assessment team, which will help to identify the appropriateness of residential care and for services, and the My Aged Care website with Rachael Dobbins, who will be able to speak much more about after myself. But what are we doing this for? That's a hard question. The National Dementia Strategy in England has a goal of maintaining patient independence and functioning in the home as much as possible. For a very specific and clear financial incentive, it's expensive. They want to try to avoid expensive nursing home admissions, which is why most of the funding for the National Dementia Strategy is about early prescription of cholinesterase inhibitors in order to minimize the nursing home costs. We don't really have an Australian equivalent for a national dementia strategy. Each individual local health district has different perspectives about what is supposed to be provided for aged care. And we don't really have a current plan for adequate mental health care in residential facilities. Mental health remains a very serious blind spot for most residential facilities. As an example, currently there still is no mechanism for funding psychologists to provide interventions into aged care facilities. Which comes to the issue of cultural management. Culture has a great deal with regards to expectations for the older persons. And most of this culture is around the issue of the traditional norm in that the youngest daughter or the eldest son is the person who's responsible for looking after their elderly parents in the home, which is filial, which is wonderful. But there is the very important issue to remember that people are living a lot longer than they used to. The current generation lives about 15 to 20 years longer than the previous generation. And that is a burden that not many families are aware of and recognize. They want to be able to try to provide for their parents the same way that their parents were provided for from their previous generation. That is harder to do without significant changes towards the cultural models. And we have to bring it back to the patient. Where is your patient going to be happiest? And have they been prepared adequately for what is going to come? And does the family want to spend 20 years on average resenting the burden that their loved ones become, or do they want to have memories that they can treasure? And a really important thing is that if an older person has cognitive impairment or is suspected to have dementia, they need to know there is an incredible amount of damage being done by well-meaning families who decide not to tell the patient that they have dementia. It is absolutely their right to know that they have dementia. If it's withheld from them, they become the screaming person in the corner who doesn't understand what's going on. An early acceptance of what's happened to themselves and what they are going to be coming through helps the likelihood that they are going to be able to go through the grief reaction and accepting their diagnosis and becoming the calmer, happier person with a superior quality of life later on. What are the cultural options? There is the Transcultural Mental Health Service is a not very well known but extremely valuable national resource. It's important to have volunteer organizations from particular backgrounds. Religious support or religious organizations provide a great deal of excellent support for older people. And it's also important to know that there are different nursing homes that will provide for particular ethnicities, and which is particularly useful in terms of these respite options well before the person requires permanent placement. So, with all of these in place, what do we think about older people, about people as they get older? Um, there is a very common theory that older people suffer from worse mental health, and that is certainly true with regards to cognitive impairment and dementia. However, in everything else, that's not the case. The worst period in a person's life with regards to mental health features is approximately 14 to 25, at which point all the depressions and psychoses are at their peak. And things are consistently supposed to improve as they get older. There is less depression, there is less psychosis if it's well treated. That's not true for suicide. So this graph shows suicide rates between the individual age demographics, the blue line representing males. And by far, the highest risk for suicide is within males aged 85 and older. And this is the Australian 2014 statistics, but it's also true for, but this rate has this pattern is not just Australia specific. It's also been found in the US, in the UK, in Hong Kong, Singapore, and Taiwan and China. And why that is difficult to understand. Most theories center around the idea of a loss of role. Males in particular very much suffer from the need to define their identity in terms of their productivity. And productivity is a serious problem when it comes to how older people are treated in Australia. The Human Rights Commission undertook a review on ageism in November 2012, with 50% of the public feeling that discrimination occurred in healthcare systems. And more than a third of older people had experienced age-related discrimination, and 1 in 10 businesses had an age above which they would not recruit, which was an average of 50. So for our older person who is responding to more of this ageism and these negative features and feeling a sense of loss of role, what can they look forward to? This was the feature of something called the Harvard Study of Aging, which is the largest study of its kind, and it was originally following a cohort of about 880 Harvard students, who with 2 other cohorts since added, and these individuals have been studied twice a year, every year, for approximately the last 70 years, with their children now being recruited into the same studies. And what this has been doing is about looking at the decisions and experiences that people have gone through, with the idea of trying to work out what is most associated with happiness. So the end stage has always been about looking at happiness. The slide that I'm showing you shows the Ericksonian stages of personality development, with one addition which was determined from the Harvard study from George Vaillant when he was the president of the Harvard study. George Vaillant looked at the studies for people who were aged 60 to 75, and he found a continuous trend. People between 60 to 75 who were involved in any activity that involved transitioning the products of wisdom from one generation to the next, which he called keeper of the meaning, were associated with happiness. So if they were grandparents teaching their grandchildren, if they were mentors teaching apprentices, if they were teachers or lecturers, if they were writers, if they were doing anything that involved transitioning what they had learned earlier on in their life to the next generation, they were happier. And this is a very important feature because it was consistently the most likely to be associated with happiness and an improved sense of identity and stability of personality development, which has obvious repercussions for our vulnerable older adults. So the basic issues for older adults is most of them don't really know what they do when they get older. Most of them have survived longer than their own parents did. And if their lives are not fulfilling and if they're isolated, it is a recipe for mental illness. We know that healthy aging does require good physical care, but even with this and even in the absence of mental illness, there can be serious repercussions. So for psychosociocultural management, which is imperative for those dealing with aging, there are psychoanalytical approaches in terms of having a qualified psychotherapist to be able to provide same. But those are very few and far between. It's much easier to look for interventions that encourage socialization, such as the University of Third Age, which is a wonderful resource focusing around adult learning. There is Probus, which is a roving lecture circuit, also with the idea of community engagement and adult education in general. Culture-specific opportunities, again, focusing on socialization, and most importantly, any personally fulfilling activity which involves a younger person. The issue is about keeper of the meaning. So, in summary, with regards to the psychosocial cultural management, we want to empower the patient, prepare them for the future, treat the family, ensure that they're supported, and staying up to date regarding local available resources. And that concludes discussion about how to keep older people out of residential facilities and pharmacological and psychological management of BPSD. And I shall now open for questions.
Thank you, Dr. Neil. I had one question coming through, and it's quite extensive.
Yep.
Is there any merit in the peanut butter test as a diagnostic test to detect Alzheimer's?
In the what, sorry?
In the peanut butter test. Peanut butter test.
Sorry, I'm finding it a bit. Is it possible to write it down inside the chat box so I can see what that is?
Yes, just.
With regards to the test, is that because there's quite a few different tests out there which purport to study for Alzheimer's, and they generally center around the identification of amyloid, either inside cerebrospinal fluid or in serum. Here we go. Oh, peanut butter test. Yeah. Very, very non-specific. I think that's if I understand correctly, is that I believe that's referring to a sense of change in taste, which is very, very non-specific between Alzheimer's and vascular dementia and even normal aging. In terms of screening patients for dementia, the first thing I think is to try to look for people who are having any sort of socio-occupational functional impairment. Is there anything are they noticing any problems with their memory? Are they finding any difficulties with driving? Are they forgetting things from point to point? one of the most important things to rule out is a lot of people present for concerns about cognitive impairment because they go into another room and they forget what they were doing in the previous room. So this is called geographical memory, which is entirely normal. Where we tend to get more concerned is where these sort of memory impairments continue and then start to cause difficulty in their day-to-day functioning. Most proponents will say that you cannot diagnose dementia without a person having socio-occupational impairment. Now, the question here is mild cognitive impairment, because mild cognitive impairment by definition is where you have cognitive changes, but you don't have the socio-occupational impairment. The challenge for mild cognitive impairment is we don't have any evidence-based intervention for it apart from exercise. And the reason why we are so careful to look for mild cognitive impairment is we are waiting for the next killer drug, which helps keep people at mild cognitive impairment and prevent it from progressing on to dementia. But beyond that, it's very hard to say anything else. So I would argue that the best point for screening and discussing advanced care planning is to start as soon as there is any information regarding an impairment in their daily functioning, which appears to be related to cognitive changes. Now, so most of what people are aware of is on a memory change issue. It's worth remembering that the frontotemporal dementias don't usually present with memory, although they can. They may not present with initial memory changes. They usually present with personality changes, a coarsening of the memory with a coarsening of the personality with increasing irritability and agitation. And that also will necessitate screening for dementia. In terms of screening, I usually recommend doing the mini mental and a CLOCKFACE, and then considering imaging. Within those three, it's very difficult to miss any form of dementias.
Thank you, Dr. Neil. There is one more question. I've just sent it to directly to you.
Okay.
If there is only issues with short-term memory on MMSE, but there is significant issues with the patient neglecting their health, partially due to depression, are they considered to be cognitively impaired?
No, that is a very important issue. And this is what Leslie Carlo meant by pseudodementia. A lot of people were thought to have dementia as a result of depressive issues impacting on their subsequent health. The best I can think for screening for depression is the geriatric depression scale, specifically the 15-point scale, not the 30-point scale. So the 15-point GDS, or geriatric depression scale, if you use a cutoff of 8 to diagnose depression, it has 100% sensitivity for identifying depression. And these patients, when you start onto an antidepressant, the antidepressant that I recommend using is usually citalopram or mirtazapine, but the most effective being venlafaxine. This can be seen to have quite a significant change in the GDS and then helping to track what's happening with the patient. And the challenge here is that a person who's depressed can have false negatives on their cognitive screening. So a person who is depressed has difficulties with their memory issues, and you can't actually differentiate between depression and dementia using an MMSE. But if there is any suggestion of depression, that's what the GDS is so useful for. So trying to make sure that you have appropriately ruled out depression before going down the dementia perspective is extremely important. I once had a patient with psychotic depression who spent 2 years in a nursing home and on escalating doses of risperidone with no change. It was discovered that she actually had depression, and she was started on an antidepressant, going on to electroconvulsive therapy. The depression was well treated, and she actually left the nursing home and she went back home because it was found that she had no cognitive impairment. So this is an extremely important issue that must not be missed.
Thank you. And the next question is, do you agree that older age housing for aged persons can provide a good atmosphere for retirement?
Do I agree that what, sorry?
Do you agree that older age housing for aged persons can provide a good atmosphere for retirement?
Well, yes, I think it'd be difficult to disagree with that. The problem is what kind of older age housing? So residential facilities have come a very long way just in the last decade. It it used to be purely doom and gloom, extremely low quality dormitories with horror stories of kerosene baths and the like. One of my favorite residential facilities is a caravan park in Dural, which is the only caravan park in the world that has dedicated garden plots. They were a caravan park like anyone else, but over time they had more and more grey nomads who were turning up there and setting up and staying, and applied for registration as a residential facility and got it. They had an incredibly nice village. There was people who, as they got as they physically decompensated, didn't move around as much, but they had friends in the area, a wonderful village atmosphere, and a sense of freedom associated with same. So the range of potential aged care facilities and aged care services out there is huge. You can have everything from private resorts to isolated nursing home environments and locked dormitories, and it really depends on the individual. And there is a facility that I'm aware of, for example, that had a very large Sri Lankan community and had quite a lot of difficulties in terms of people being uncomfortable with the nursing home environment until they changed their caterer and they started providing Sri Lankan foods together with curries and things that were more fitting with the person's culture. And the quality shot up. Reports greatly improved. Analgesia use dropped. BPSD concerns dropped as well, just simply due to the caterers. So depending on the residential facility, how creative the individuals are, and what the local services are available, you can have incredibly good results for all the people.
Thank you, Dr. Neil. I have no more questions, and I would like to thank you for taking your time tonight and present such a comprehensive information presentation.
Okay.
Thank you very much.
Not a problem.
I would like to move on to our next presenter, Rachael Dobbins, who will speak on the aged care.
Good evening, everyone.
Rachael. Hello.
Thank you. Good evening, everyone. My name is Rachael Dobbins. I'm one of the service managers within the Aged Care and Rehabilitation team within Sydney Local Health District. So this evening I will be speaking with you regarding a range of different subject matter, looking at aged care services and how to access those services. So some of the content that I'll cover is around my aged care, referral pathways to my aged care, consent and information sharing, assessment teams, so our RAS and ACAT teams, Commonwealth Home Supports programs, home care packages, residential respite and permanent residential care. So it's a fair bit of information to cover off, so hopefully I don't move through it too quickly for you, and I'm more than happy to take questions outside of this session as well if that's helpful for you as well. I like to use this as a lovely way to describe the aged care system. It's very confusing to most of us that work in it, so I do pity people trying to access services for themselves or for a loved one. So it can be very confusing. My aged care. So my aged care commenced in July 2015, and it was originally set up to be a one-stop shop, if you like, for people wishing to access Commonwealth-funded aged care services or to work out what services might be available within their region. The whole idea of my aged care is to centralise client assessment records and to centralise how we can identify what services a client is accessing. It was meant to streamline that whole assessment process to limit the amount of over-assessment that had been happening for clients previously. So this slide just gives you an idea of what the My Aged Care website looks like. It's been revamped just recently, and that's the current look of it at the moment. The contact details there are quite heavily promoted to anyone wishing to access aged care services, and they're available at the contact centre Monday to Friday 8 AM to 8 PM and on Saturdays for reduced hours. There's a couple of different ways that someone can refer a client through to My Aged Care for assessment. Probably the easiest and more streamlined process for GPs to follow is the e-referral. And that can be done via the patient's electronic medical record, and it's available through a few different practice management systems. And I've included some information on this slide about how to navigate to where that referral form is if someone is not familiar. And it's important to attach as much information as you can that will assist the My Aged Care Contact Centre to triage that referral through to the most appropriate team. I've also included a link there for you about some quick reference guides that are also helpful to guide you through that process. Another option for referral is by web form, and I've included the link for that form there for you as well. If you're not using any of those practice management systems that we previously mentioned, you can use this form to make a referral to My Aged Care. Again, you can attach any particular documents or other advice that might be helpful for the contact centre to be able to process that referral. And it's really important once you submit that referral to keep a record of the reference number that you're supplied with. If you do need to follow up on that referral, all you need to do is to quote that number and they'll be able to assist you. Another option is by phone. There can sometimes be lengthy wait times to do that, but it certainly is an option for you. If you do decide that that's the way you would like to make a referral, it's really important to have information at hand to be able to make that referral. The contact centre will ask for information around client-specific details, contact details, date of birth, all of those sorts of things. So it's important to have that with you at that time. You could also ask the client to call My Aged Care directly if they're in a position to and have capacity to as well. They still also receive fax referrals, strangely enough. So that's another option for you, but probably the least attractive option. The other three options might be better for you. But again, I've listed that link there for you should you wish to use that as an option. This slide just gives you a bit of a visual around what that referral pathway could look like for a client once they've been referred to the My Aged Care Contact Centre. On the left-hand side, you'll see that the My Aged Care Contact Centre will do the registration and screening for a client on receipt of a referral. And based on the information that they receive as part of that referral, that will help them to determine which type of assessment is most appropriate for that client. So that could be the regional assessment service, or it could be the aged care assessment team. Once that's been determined, that will then flow through to an assessment. So you'll see up the top where we've got the regional assessment service listed. That will then flow onto an assessment that will have outcomes of referrals to programs funded under the Commonwealth Home Supports Program. And if the referral goes through to the aged care assessment team, that assessment will result in a range of different outcomes, which could be for residential aged care, it could be for home care packages or for flexible care types. They then flow through to service delivery. So it's a fairly high level diagram of what the process looks like. And I'll go into a little bit more detail for you now. So there's some issues around consent and access to information with My Aged Care. When someone is registered with My Aged Care, they could have two different types of representatives listed on their record. One representative type is a regular representative and the other is an authorised representative. If someone was to contact My Aged Care and they are not listed as a representative on a client's record, My Aged Care won't release any information. They'll only give very generic aged care information. So it's important if you have a patient that you feel would benefit from having a representative attached to their record, I would encourage you to encourage a family member or an advocate to have them registered as a regular representative so they can support someone through that My Aged Care process. There is a form that can be filled out if verbal consent to add a representative isn't possible, and I've included the link at the bottom of this slide, so that can be helpful for some people as well. So a regular representative on the My Aged Care website basically has access to the same level of information as a client would if they were contacting My Aged Care themselves. So they could be able to find out what assessments have taken place, what services have been referred to, what services are currently in place, and if there's any other pending assessments in the system as well. An authorised representative is someone who has guardianship in place, an enduring power of attorney or guardian, and documented evidence needs to be supplied to My Aged Care before someone can be registered as an authorised representative. So an authorised representative has the same capacity to interact with My Aged Care as a regular representative or as a client. So next I'll move on to some information about assessment services that will distinguish the difference between the Regional Assessment Service and the Aged Care Assessment Team. So as I said, there's two different types of teams that do two different levels of assessments. So the Regional Assessment Service, which is often referred to as RAS, they provide a basic assessment for entry-level services that are funded under the Commonwealth Home Support Services Program, or CHSP. And then you've got the Aged Care Assessment Team, or commonly known as ACAT, that provide comprehensive assessment for different types of Commonwealth funded services under the Aged Care Act. And they'll also assess for eligibility for CHSP services as well. So the Regional Assessment Service. So the Regional Assessment Service is comprised of non-clinical assessment workforce, and they'll assess for those entry-level programs mentioned previously. So that could be things like Meals on Wheels, personal care, domestic assistance, and similar types of services. You can't access Commonwealth funding or CHSP services without a RAS assessment if the client would like to access them on a longer-term basis. There's currently within the Inner West region 3 RAS service providers. So New South Wales Health is one of those service providers. Community Options and Aged Care Assessment Services are two external to New South Wales Health. So in terms of the Commonwealth Home Supports Program, again, it's entry-level services, single service types that are generally aimed at frailer aged people. Designed to maintain independence and enable older people to remain living at home for as long as they wish to do so. And there's a big focus at the moment on reablement as part of this program. It's really not designed for clients with complex or multiple or intensive care needs. And it really should be at entry-level services, so the equivalent of a level 1 home care package or less than $8,000 per annum. There are fees that are applied to the CHSP services. They are subsidised, but often charged at an hourly or daily rate, depending on the service type. There's limited availability of CHSP services, generally speaking. However, at the moment with COVID, there is some additional funding available, and there is some capacity within services at the moment, which has been greatly appreciated to be able to support clients. And the CHSP program is currently funded through until the end of June 2022. So these next slides is just some information about particular types of CHSP programs that can be available. So it is quite broad and diverse, including some clinical services as well. So I'll move on next to the Aged Care Assessment Team. So the ACAT team comprises of a multidisciplinary team. In the Inner West, we have a range of disciplines within our team. We have OTs, social workers, nurses, physiotherapists, and we have a speech therapist on the team now as well. So the ACAT team conduct comprehensive assessments. They do those assessments either in the client's home or in an inpatient setting. And for our team that covers the Inner West region, we have staff based at Royal Prince Alfred Hospital, Canterbury Hospital and Concord Hospital. And the ACAT contract is solely operated by New South Wales Health, and that contract is through until mid-2022. The ACAT team will approve for home care packages, residential respite, permanent residential care and flexible care. So under that flexible care umbrella is transition care, the transitional care unit and short-term restorative care as well. So who can access an ACAT assessment? So generally older people over the age of 65 or 50 for our Aboriginal and Torres Strait Islander community, and generally for people that are needing regular assistance with daily tasks or clients that may have more complex care needs. Younger people with a disability are also being referred through to the ACAT team for assessment, generally where they're not eligible for NDIS and all other age-appropriate options have been exhausted or are not appropriate for their care needs. We're finding an increasing number of those referrals coming through. So I'm just going to move on to some information about home care packages for you. So a home care package is an allocation of funding for service provision within the community. Exactly how the funding is used is determined by the individual in accordance with home care package guidelines and is delivered under a consumer-directed care model, so very much so client-centred. The client can choose to access a range of different services under that home care package, and some examples could be face-to-face assistance with things like showering, dressing, transport, meal preparation. There could also be allied health input, equipment provision, consumables such as continence products. And the funding for the home care packages is allocated to the client's chosen service provider monthly. So it's not a yearly block of funding, it's allocated monthly. So there's single levels for home care packages, level 1 being entry level all the way through to level 4, which is more complex care needs. And the approximate funding allocation per year I've listed there for you, so you can see how it increases from a level 1 all the way through to a level 4. And again, the funding is allocated monthly, not annually. There's a national prioritisation system for funds to be allocated. So waitlists for home care packages are no longer held regionally, they're held nationally, and that's managed by the My Aged Care system. Currently, as we speak at the moment, the wait time for the home care packages level 2 through to level 4 can be 12 or more months. Some clients who have been allocated level 3 and level 4 home care packages have been waiting up to 2 years, unfortunately, so that is quite a lengthy wait time. A client can opt to join in the national queue from the date of the approval of their home care package, or they could choose to join that queue at a later time, and there's no disadvantage if they do choose to access that queue at a later time because they will be placed on the queue from the date of their original approval. There's 2 different levels that someone can be placed on the national queue for their home care package, medium and high. So medium is the bulk of clients that would be assessed for a home care package. That's the priority that they would enter the national queue. A very small proportion of clients will be approved as eligible for high priority on the national queue. What that means is that they will leapfrog everyone else on the national queue and go straight to the top. So high priority is really for people who are at immediate risk in terms of their personal safety. There's been a complete breakdown of the care arrangement or the carer is at crisis point. Again, really a small number of clients are eligible for high priority, and it certainly doesn't guarantee quicker access to a package. It certainly doesn't mean immediate access to a package either. A change in priority requires a new ACAT assessment as well, and there's no access to emergency home care packages anymore. So there are 2 types of fees that apply to a home care package. There seems to be a bit of misinformation out there in the community at the moment that home care packages are free. They're certainly not free, unfortunately. There are 2 types of fees that may apply. So the first fee is a basic care fee, and you can see it's a sliding scale from level 1 through to level 4, with the maximum rate that can be charged for a basic care fee is on a level 4 package of 17.5% of the basic aged pension, which equates to $75.25 per week. The other type of fee that could be applicable for a client accessing a home care package is an income-tested care fee, and that's determined via an income assessment that's processed by Services Australia, and that amount is reviewed quarterly by Services Australia as well. So I've included some information here about the maximum amounts of income-tested care fees that could be applicable to a client. And you can see that it can be up to $30 per day. So the income-tested care fee is really about assessing whether someone can contribute more to the cost of their care. There is a lifetime cap on these fees of $67,500, and these caps are all indexed March and September each year. There are financial hardship processes that can be accessed for people who are in genuine financial hardship. So those types of assistance can apply to basic care fee and also the income tested care fee. Application forms for this type of assistance must be completed and lodged with Services Australia by the client or the client's representative. Another really great source for information around finances to do with home care package is the Financial Information Service, or FIS. It's free advice. They do support and seminars as well. The service is available Monday to Friday, and I've included the contact number there for you as well. Residential respite care. So that really enables an individual or a carer to have a break from the usual care arrangements in a residential care facility. ACAT must approve someone for either high or low respite care for them to be able to access that. Every client can have up to 63 days of subsidised care per financial year, and 21-day respite extensions can be approved by ACAT, and there's currently no limit to the number of respite extensions that can be approved, but there needs to be valid reasons for those extensions to be in place. In terms of fees around residential respite care, the maximum daily fee is set by the government at 85% of the single basic aged pension. So currently the daily rate for someone accessing residential respite could be $52.25 per day, but no accommodation bond is required because the stay is temporary. Permanent residential care. So when an individual is no longer able to manage at home and requires more assistance and supervision that can be supplied as part of residential care, this could be a suitable option for them. Aging in place is a really important thing to consider, and hopefully there should be really no need for a client to have to change facilities as their care needs change. Again, this requires approval for ACAT to access permanent residential care. Fees, there's a range of fees that may apply, and it really depends on the facility that someone's wishing to access as to what types of those fees might apply. And we really recommend that people who are seeking to access permanent residential care gain some financial advice around that, and whether that be through the Financial Information Service or through a private financial advisor. It's really worthwhile that they access that information and support. The My Aged Care website also has a fee estimator where you can go online and enter in your current situation, and it will give you an estimation of what some of those fees could be should you wish to access permanent residential care. So these are some of the resources that we find quite useful as an assessment team, not only for ourselves, but also to direct clients and family members too. So I've put all of those there for you. Any questions?
Thank you, Rachael. There is one question so far. Is the home care package available to Australian citizens only? So I guess question on, yes, citizenship and permanent residency.
Yes. So basically someone has to have access to Medicare to be eligible to access a home care package.
Okay, thank you. No, I don't have further questions as yet.
Okay. I'm happy to take any questions. As I said, outside of the session, I've included my email address as well. If anyone has any further questions, I'm more than happy to take those. Oh,
sorry, it started to come through. Sorry, just 1 second. I'll set them. So the question is on, or comment rather, that the process is complicated, which you mentioned at the beginning, and person is saying that they feel like they need a social worker to help people with applying and getting results.
So there's currently a trial that's in place, and it's called the My Aged Care Navigator trial. And that trial was put in place in recognition of the fact that there are people who are feeling quite lost trying to navigate the system. And the whole idea of this trial is to support people accessing My Aged Care, having themselves registered and understanding that process. In saying that, our experience as an assessment service for both RAS and ACAT is that we're providing a great deal of education and support to people just trying to understand the system and trying to link people up to the appropriate services. So certainly I would agree with you that it is a very confusing system, and hopefully some of the work that we're doing is trying to minimise some of that, that feeling of being lost.
Thank you. The next question is, what is the typical wait time at the moment for original ACAT assessment to placement?
So in terms of wait times for assessments, it depends on the priority of the that's been assigned to the referral that's gone through to the assessment service. So from the My Aged Care Contact Centre, a referral is issued to the assessment service, whether it be low priority, medium priority or high priority. So the maximum wait time that someone should really be waiting for a home care package should be about sort of that 4 to 5 weeks mark. Sorry, for an assessment should be 4 to 5 weeks. But bear in mind though, if you've got a client that you're concerned about that you feel needs to be seen sooner, by all means get in touch with your local ACAT team if that's where the referral has gone to, or the RAS team if you know which team it's gone to, and let them know about your concerns and they can certainly prioritise that assessment.
Thank you, Rachel. And one more question that came through just now. How do things vary with veterans?
How do things vary with veterans? Was that the question?
Yes. Thank you.
So it's very topical. We've been having this conversation with veterans recently, and they've really advised us that their services are pitched at entry level, so very similar to the Commonwealth Home Supports program. So when someone's requiring more coordinated approach or has more complex care needs, they're referring clients through to My Aged Care to be assessed by the ACAT team. So that they can access a home care package. So we're working with them at the moment to try to understand what the tipping point is for them to refer through to us so that we've got a clear understanding and can support those clients through that process.
And that's all for the questions so far. But yes, as you, Rachel, mentioned, there is your email address, and I understand that participants can email you if you know, after the presentation with the questions to follow up as well.
Yeah, absolutely. I'm more than happy to assist in any way that I can.
Beautiful. So a couple of more seconds, no new questions are coming through. Therefore, I would like to thank you for taking your time tonight and presenting all this really difficult sort of information in such an easy way. And I would like to thank everyone for attending.